Hello, everyone, and welcome back to Psychedelic Vantage. Today, I am speaking with Dr. Sulman Aziz Mirza. Dr. Mirza is a triple board certified psychiatrist with expertise in psychiatry, child and adolescent psychiatry, and addiction medicine. Dr. Mirza has worked in a variety of settings from inpatient psychiatric units with medical capabilities to the classrooms of Baltimore City public schools. He has learned from some of the leaders and pioneers in the field of psychiatry, and his experiences have allowed him to develop a deep understanding of neuropsychiatric conditions in both children and adults. Dr. Mirza also has by far my favorite YouTube channel focused on mental health called The Kick Shrink. It has been really beneficial for me, both in terms of education and in helping me on my own mental health journey. So the goal of this interview is to learn more about current treatments for depression, new and emerging treatments, and at the end to hear Dr. Mirza's views on the potential of psychedelic medicine. For example, what do and don't we know about psychedelics as a potential treatment from the current research? Dr. Mirza, thank you so much for coming on the channel today. How are you doing?
Good. Thanks, Jake, for having me. It's always a honor to come on and spread some words, I guess, right?
Thank you so much. I'm really looking forward to this one.
Yeah.
So, can you share a bit about your background and what led you to pursue a career in psychiatry, particularly in areas like addiction and adolescent psychiatry?
Yeah, there's like the long version and there's like the short version. So I'll kind of try to bridge the two of them because I think it's important in my own journey. So a little bit of background on myself. So I'm the first son of Pakistani immigrants. My mom is a family physician. My dad is an environmental engineer. So I was, of course, given the opportunity in my life to become a doctor or to like not be a member of the family anymore. Essentially, the whole standard Asian stereotypes are there. So I was going to rebel a little bit, and I initially was going to be like, screw being a doctor, I'm going to become a dentist. So I initially started off going to dental school after college. And it turned out that I did not do well over there. I actually failed out of dental school after my second year. And a lot of it, in retrospect, was kind of due to undiagnosed adult ADHD. So this led to like a little bit of a, I don't want to say a spiral. I came back home for the year as a failure, a disappointment to my family, to the community, all that fun stuff. It was a wonderful time in my life. But a cousin of mine reached out, was like, hey, think about going to like a Caribbean medical school. They'll accept you if you just like apply. And I was like, all right, fine. Well, you'll see what we can do. So I ended up going to Caribbean medical school, worked my ass off over there. Like it was, people think that Caribbean medical schools are like this easy way to to become a doctor. It's like, they're not. They're just kind of like money making machines because they will fail you and have you repeat like classes over and over again as long as you can pay tuition. So you'd go there and there are people who'd be on the island for like years because they're just not progressing. They're not passing classes and they just have somebody to keep paying the tuition. So I use this number to not to kind of like shock people or to kind of say the reality of the situation is I started off with like 150 people in my class of September 2008. And when I graduated in April 2012, the normal 4-year schedule or plan that we think of for med students, there were 15 people of that original 150 that made it through and matched into a residency position. Mm. So 90% attrition rate, right? Wow. That's pretty significant. So again, I had a bunch of people, classmates make it the next year, but again, like the people on time, not that much at all. So it's a constant kind of struggle there. And I somehow like really buckled down because I knew my back was against the wall and like what the alternative was. And I made it through. And then, I fell in love with psychiatry along the way during my rotations in med school. I was like, wow, this is super interesting. This is so different from like what I was expecting, what people were telling me what psychiatry was, what it was looking like on paper. Getting a chance to talk to patients, get their experiences. That's the thing that really drew me to the field. Mm. Where so much of like regular medicine, when we talk about like internal medicine, family medicine, surgery, was so like algorithm based. so much as like, if this, then that.
Mm.
If that, then you do this. And again, just following it down, it became very plug and chug. With psychiatry, when it's done properly, because there's a lot of controversies and stuff online about how it is and how it's not. But it was like, when it's done properly, like, you make a connection with your patients, you get to talk to people, you have interventions, and you can change people's lives positively, potentially negatively. So that's what really drew me into there. I really like the art part of it versus necessarily the science part of it, which again is a critique plus also, pro, depending on how you look at it, about the field. And that's what got me into the field of psychiatry. I really liked child and adolescent work, because you really have an opportunity when you get in at an early age to change people's trajectories in life. The story that really stuck out to me was like, there was this girl that we saw, and I'll change the story a little bit just to protect, even though it was like 15 something years ago, there's no way to people connect to anything. But like, I saw them when I was on my rotation, and they had this horrible history of like physical sexual abuse as a child. And they were taken out of the home. They were adopted by this like gay couple. And she was at that time, like, got into therapy, got into psychiatric care, got a lot of work done to help her out. And she, by the time we saw her as like an outpatient when I was a med student, she was having like normal, like 12-year-old girl problems, right? That like, if I'm looking at it, I'm like, oh my God, reading this story, I couldn't expect this person to function. And like, what would her like trajectory in life have been? Would have been totally different if there wasn't this intervention that was done, where she was able to get support and get help and like function as a normal, regular, quote unquote, 12-year-old girl. So that story like really stuck out to me, and I was like, I want to work with kids. I'd always wanted to kind of work with kids, either doing like pediatrics, but then this was kind of like a melding of that. And then the addiction medicine part came about because I kept seeing over and over again during my psychiatric training that substances were involved, right? With like everything. There's so much of an overlap of like substances. And a lot of times, even among psychiatrists, people are like, oh, that's a substance issue, so I'm not going to worry about it. I'm going to refer them to like somebody else, and then they can worry about like the substance part. Where when you actually like look at it, like, so much of addiction work is rooted in mental health stuff. Like, the things are just, they're intertwined. Like, you can't separate them. And we know that like substance use is so connected to untreated depression, untreated anxiety, untreated ADHD, untreated schizophrenia, bipolar disorder, or self-medicating, self-treating it, that it's like, how can you not like become an expert and be like very familiar with this stuff? And, so that's what really pushed me into there. And then when I was able to work with a lot of people, again, during the raging opioid epidemic, which is still going on, like, and you make those changes and interventions, you get people onto like something like Suboxone, it's overnight change of a person's life. Like, there's no greater impact I've seen from like month 1 to month 2 than somebody who gets somebody off of, using illicit, substances, getting like illicit oxycodones and other stuff off the street. And then you get them onto something like Suboxone. A month later, their whole life is different, like dramatically different. And I was like, this is like, again, a very black and white, that ADHD part of me that comes in of like, you want that instant reward of like, oh, I did something and something was, like I could see tangible differences that I'm making, like that was a thing for me. So I think that like, again, a little bit long, but like, that's what brought me to where I'm at. That's how I got into what I'm doing.
Thank you so much for the really comprehensive background. And I just got to say, I really love how you've shared about your own personal mental health journey and dealing with ADHD as well. I really appreciate that. And I actually, I did have a question about Suboxone because I've been trying to learn more about it. So my understanding is that, it significantly reduces the likelihood of someone overdosing.
Yeah.
And just considering how, I guess maybe especially with our viewers, maybe in the psychedelic medicine crowd of people who are passionate about that, maybe they have this idea that there's no effective treatment now for many conditions. But like, for example, with Suboxone, do you think it will start to be used more as a treatment option moving forward for opioid use disorder?
I mean, I think it's almost like malpractice that it's not. It is like the most effective treatment. Like it is, I mean, of anything that's out there, like it is, over 90 something percent effective
Mm,
for treating opioid use disorder. For
wow.
people who want to get off the medication or get off the substances, whatever they may be using, like it works. And there is nothing, I mean, except maybe methadone that compares to it. And then there's, again, methadone has its own pros and cons and hoops that people have to go through. But like Suboxone, the generic name is buprenorphine, the brand name is Suboxone. That's, just to kind of put that out there. And there's different formulations of it, but Suboxone is the most common one that's used. Um, but it works and it just saves lives. Like, it works as a partial agonist on the opioid receptors. It prevents overdoses. So even if somebody were to use again on top of their Suboxone that they may be prescribed or that they were using, is like it can prevent that overdose,
Wow. I didn't know that.
which is, again, like you talk about, you want to put an end to the opioid epidemic. Like this is the answer. And, this is why there's been a lot of legislation and changes with the laws so we can increase access to prescribers for this.
Mm. Thank you so much for that information. I learned a lot from that. And I know the viewers will as well too. So, what inspired you? You went into what inspired you to become a psychiatrist. What inspired you to start your YouTube channel on the topics you cover?
Yeah, I think it was, I started off doing a lot of stuff on TikTok during COVID, during the pandemic, like a lot of people. And I was doing a lot of more like comedy skits and kind of a little play off of like Dr. Glockenflecken, who's become very well known for being like the medical comedian, satirist. And it allowed me to connect with a lot of people and then, opened me up to a lot of the stuff that's online. When you're in practice or you're in training, you kind of get isolated about like what's going on in the rest of the world, what patients are kind of saying or talking about. So introduced me to this whole like the anti-psychiatry movements, critical psychiatry movements. A lot of people who are critical about psychiatry, of course, like we were familiar with like Scientologists and how like part of their fundamental religion is how psychiatry is like evil and child abusing and molesting and all that stuff. And we knew that part, but like again, the other part and how prevalent some of these some other ideas out, some of these other conversations are, some of the negative things that are out there, it really opened my eyes to that. So, and then also just like misinformation in general, like with COVID as well, we started to see this real mistrust of medical professionals, science as a whole, um, just in general, just people being like, no, we're questioning everything. And it's like, sure, it's good to question everything, but if something's been like, studied to death, and it's like, this whole, even when we talk about things like vaccines and autism, it was like, we're in the midst of RFK Jr. saying that we're going to devote more money and funding towards making sure that vaccines don't cause autism, or it's like, it's been done for decades. Like this is like beyond, beaten into the ground that this is a thing. So that's what really caught my eye about like, oh, this is what people are talking about online. And then even like clinically, when I'm working with patients, and I always kind of have to remind people and say to people is that like, I'm a clinician first and foremost. I'm not like a researcher. I don't do that stuff. Like I see patients. I see patients in all these different settings and I work with patients, and that's where I get the most joy from working with patients. And they'd all come to me and they'd all say something like, well, somebody on Facebook said this, or when I went home and I Googled this is what showed up.
Mhm.
So it became to the point that I was like, just even incorporating it into like my normal, like medication consent for people, right? I'd be like, so when you go home and you Google this is what you're going to see,
Mhm.
right? Or when you go on TikTok and you come across somebody saying this is what you're going to hear and you're going to see. And this is the truth. So
Sure.
that's where it really kind of started to be like, you know, let's incorporate some of the things that we're hearing, we're seeing, we're understanding that there is so much that's out there, and there's so much misinformation. And there's so many people who are not qualified that are coming out with these bold statements that then people are then basing their treatment and basing their decisions on. I've lost count of the number of times people have said, well, my uncle in like, across the country who I've never seen, like gave me a Facebook post, and because of that, I stopped my medication.
Uh, yeah.
Right. And it's like, okay. It's like, okay, right. What are we doing this? Or like, I don't want to take these medications, or I don't want to do this treatment. Or what do you think about like Reiki or energy healing, or like, again, these pseudosciences that keep popping up to treat this? And I'd be like, if it worked, I would, by all means, I'd tell you to do it. Or like, end of the day, like people have this like misconception that psychiatrists don't want people to get better because we're going to lose customers or something, like, or this statement that's out there. And it's like, I want less patients. I wish I could have less patients. I work full-time children and adolescents, and then I have a side private practice working with adults. They're all full.
Yeah.
There's like 50 hours a week that are there. Like they're all full. I have month-long waiting lists, a couple months long waiting lists for people to get into me. Like if I could discharge half my patient load, like I'll still be full. Like there is a never-ending supply, quote unquote, of patients that are out there. I want people to get better because it makes my life easier.
Mm.
Right. Like I always tell when I'm working with my residents, I work with pediatric residents who are learning, their mental health rotation is learning with me as well. As like, I tell them, I was like, one less bottle of medications with my name on it is one less thing that I have to worry about.
Mm.
Right. I don't want my name out there on stuff. Like the worst possible thing for me is somebody to overdose and my name is on the bottle.
Yeah.
I don't want that. I don't want to prescribe anything.
Dr. Mirza, I really appreciate you bringing up, this the mental health misinformation that's out there, health
Yeah.
misinformation in general. It's a really scary time. I gotta say, it is very scary. And when you mentioned vaccines and autism, I guess of course, yeah, we can ask questions, right? But
Sure.
it seems that based on my understanding, the one thing we know doesn't cause autism is vaccines, just from
Right.
what I've learned. So yeah, it is a little bit of a scary time, and you definitely tackle a lot of this misinformation on your YouTube channel, and it's extremely helpful and
Yeah.
educational. I thank you for that.
Yeah.
So I'd like to ask about, and you touched upon it a bit, your experience as a psychiatrist and the current treatments that you utilize or that are available for conditions like depression, including psychotherapies and medication.
Yeah. The idea is when we're looking at depression, and then just like any kind of psychiatric disorder, a good psychiatrist, we're all trained to create what's called like a biopsychosocial formulation of what's going on. Meaning we look at biological factors, psychological factors, social factors that are involved, and we look at things like predisposing factors, precipitating factors, persisting factors, and protective factors. We create this little grid in our head or on a piece of paper, whatever it is, so that we can get an idea of like what's going on with this person who's in front of us, right? And I give an example a lot of times, like, so a majority of my work is doing like an adolescent partial hospitalization program where kids will come or teenagers will come for a few weeks. They'll do a group setting. They meet with myself, they meet with the other docs, and they meet with like therapists, and they do group work. And, overwhelmingly, they'll all come for like major depressive disorder, recurrent, severe, without psychosis, and generalized anxiety disorder, right? They have the same diagnoses, but they all have different stories, right? They all have a different story of how they ended up in that situation or in that setting at that moment in time. So for the person, when I'm doing an evaluation, I try to get an idea of like what's happening now. What is the thing that made you come to me now? What has led you to this path? Creating a timeline of the person's events to be like, is this a quote unquote, again, normal reaction to what's happening? Or is this something that's like, again, an abnormal, again, quote unquote, reaction to what's happening that makes us say, like, hey, we need to intervene in some way, shape, or form? Do we need to do things like therapy? Is that like a better option for us where we learn skills, right? And put that into use? Or we learn more about ourselves, we processing trauma, other things like that that may be occurring. Or do we need things like medication to kind of
Mhm.
boost something along those ways? And it's really, again, I take a lot more conservative approach to maybe some of my colleagues because I'm like, I would love, again, for my own selfish reasons, less medications out there, less bottles with my name on it, because it makes things easier, right? Medications we know, like, so the typical kind of things we do for depression, like SSRIs, selective serotonin reuptake inhibitors, SNRIs, selective norepinephrine reuptake inhibitors, the classic kind of antidepressants that are out there, they're dirty medications. They're imperfect. Like depending on who you want to quote and who you want to research, like maybe 60% effective,
Okay.
right? Then that's kind of like an optimistic range of saying 50 to 60% is like what we expect it to be effective. And I think that's because a lot of times a lot of people ignore everything else that needs to occur. I use this number a lot for people is that 75 to 80% of psychiatric medications in America are prescribed by non-psychiatrists. They're prescribed by like primary care docs or nurse practitioners or somebody else, right? And people just think that if they take the medication, that it'll make them feel better. It is a magic pill and they will start to be happy and they won't be depressed. And it's like, that's not true. Like when people come to my office and they're like, I'm like, okay, we're starting antidepressant. I'll be like, but I also want you to do all these other things. I also want you to like do therapy or see if we need to make a referral for therapy. Like, sure, I can process and work on some stuff like during our appointments together, but it's not going to be the same thing as like regular, consistent kind of therapy to work through what's going on. I want you to work on your diet. I want you to work on exercising. I want you to get like more sunlight. All the boring stuff that people say that we don't say, we say it because we know that that's part of all the things that are happening. And if it's related to like, again, a normal, again, quote unquote, normal kind of reaction, somebody died, you had a breakup, some grieving process, like understanding that like those are normal, again, reactions to what's happening and until they don't become normal,
Okay.
right? So until they don't become, right? Which is when people are like, I want to die, right? People become suicidal or they're doing self-injury or they're engaging in high risk behaviors. That's again, like what falls into the realm of like unsafe, abnormalish kind of reactions to something that occurred.
I see. And I'd like to ask you, in
Mhm.
America, and you actually did bring up 75% of SSRIs, I believe you said, are prescribed by primary care physicians. So that also makes me curious to ask, yeah, in America, do most people, when they're dealing with depression, do most of them start off with psychotherapy, or medication?
It's hard to say, but I think there's valid criticisms about like the overprescription of psychiatric medications, the valid concerns about overprescribing of antidepressants specifically, because I mean, again, going back a little bit, like there is a massive shortage of mental health workers, professionals. And if this is something that's always going to be there for,
Mm,
something that I've kind of accepted in my life is that like never at any point in my life will there be enough mental health workers for what is needed. Therapists are, again, like a therapist is only really going to be able to see, and if if they're delivering like weekly therapy with somebody and really high quality therapy, they're going to be able to have a case of maybe 20 to 30, 40 people,
hmm.
right? Which is so small.
Yeah.
And then they're not paid great, right? We have issues with kind of insurance reimbursement, mental health parity with payers. Mental health has always been looked down upon, and that kind of gets impacted with payments as well, on that level. So you don't get as many people going into that field. There's not incentives for people to go into those fields, so you don't have enough workload. And we also have issues in regards to um, just with psychiatrists. So like even myself, like I have a caseload of a few hundred people.
Wow.
Again, like I can reach greater numbers,
Mhm.
but I'm not having that same, again, weekly kind of impact that people, that a therapist may be having as well. So unfortunately, we get into the situation that just based on like people trying to get help, when people are like, okay, I'm gonna make a referral for therapy for you, and it's gonna be 6 months before you can get into therapy.
Mhm. Mhm.
People go into the office and they want to leave with like something. So a lot of times people will go to the primary care doc, I'm feeling depressed, here's a prescription.
Yeah.
And that's how we kind of end up in that situation. And then again, a lot of times people will be like, well, it didn't work. Because of course you're not doing all the other things that need to go along with it. Not any fault of themselves, right? A lot of it is due to just like, we don't know what to do. People don't know what to do. People don't know how to get connected to what they need to do. And just the people not being there.
SRIs and SNRIs being, I guess, frontline medication for conditions such as depression. I'd be curious to also ask about, I guess, new emerging treatments such as Auvelity, for example. I believe it's considered, and correct me if I'm wrong, a rapid acting antidepressant
Yeah.
for major depressive disorder. And also recently we've seen promising data from this drug Caplyta
Mhm.
for as an adjunctive treatment. And the data, I guess I've only been following clinical trials not for too long, but it looked to be like maybe more effective than the current medications.
Yeah. So Auvelity is an interesting medication in regards to it's a combination of an antidepressant that's already out there, Wellbutrin or bupropion is the generic name, and the cough medication dextromethorphan. So which can be used, has like its own kind of like second life as like a hallucinogenic kind of psychedelic kind of agent as well. Um, so the idea was like when these two medications got combined, people were noticing like a benefit in depression pretty quickly. And I've got like, I think one, maybe two. I'm trying to convince this one of my patients to try it. One person who's done it and about them, they had been on like all kinds of medications in the past. They've done all kinds of different treatments. And this was the medication that worked for them. This was the thing that like got them to turn around to be like, I'm no longer depressed. I'm like no longer in that phase of being like chronically suicidal. I don't feel like I want to die anymore. So that was really helpful, really beneficial for the one person. I'm trying to convince this one other person who was a similar kind of background to be like, let's try it out. Um, so bupropion is different. It works differently from SSRIs. It doesn't affect like the serotonin receptors or that part of the brain as much. The dextromethorphan works a little bit on NMDA receptors in the brain. So that combination has been shown to be, again, like within a week or two, provide like really rapid results for depression. I think the studies also show that like over the long term, it kind of works out the same as a lot of like the other antidepressants. It just kind of gets people there faster.
Okay,
Yeah.
thank you. And
Cap,
also,
yeah.
yeah, Caplyta. I
I was
want
gonna say Caplyta is more of like something that's used more for like depression and or like bipolar disorder as well as like I think schizophrenia as well. But I don't have like super. I think I have like one person on it, and they were started um, elsewhere on it. They came to me on it, and it seems to be very helpful for that person. I I don't know all that much. I don't want to like talk out of pocket
to.
for it, um, but it is definitely something like I think that's on the radar for an up and coming one. The main thing with Caplyta, it is a newer medication. It is more expensive, so it's another reason that I try not to use it as much,
Okay.
just because it costs like a bunch of money. It's not generic, so that can be something on the radar for sure.
Okay, I see. And I think it would be, before going into the topic of psychedelic medicine, I think it would be helpful for the audience to learn more about current and emerging treatments for treatment-resistant depression, and I guess treatment-resistant depression specifically because at least you have a lot of groups researching psychedelics for TRD.
Mhm.
So, and my understanding is we do have some effective treatments for TRD now as well. Of course, they don't work for everyone, but
Yeah.
there's a lot of really promising research. I guess what do we have now for people who are failed by the current standard of care?
Yeah. And so I'll kind of going back even a little bit when you're talking about TRD, treatment resistant depression, this is one of those like kind of insurance like names or words, that phrases that kind of like have popped up. And treatment resistant depression just means like somebody has tried, I think, two or more medications for depression and it's not worked.
Mhm.
That's all that it means, right? So there's again a lot of kind of like discourse online about like, oh, these people are being throwing labels at patients, and like the psychiatrists are throwing labels at them, and they're blaming the patient instead of like the medication. It's like it's not necessarily that. Again, it's just like a BS kind of insurance term that's out there in the world. And so for people with, again, not had positive responses with more than two antidepressants or treatments, they get this kind of additional label where it's like, okay, maybe we have to think outside the box a little bit more. So that may involve different kind of treatments, which may be like an antidepressant and another antidepressant, like two antidepressants, or an antidepressant and an antipsychotic medication, an antidepressant with like a bipolar medication, or using a stimulant. So it's again like you start going to things like combinations of medications or combinations of different classes of medications to help with treatment. So that's like the old school way of, I guess, treating treatment-resistant depression. The other kind of way is through things like originally was through alternative treatments, things like ECT. ECT was the first one, first like main kind of alternative treatment that's stuck around to this day and is super effective for people. So that's ECT. Electroconvulsive therapy is more commonly shock therapy, has its own kind of like stigma associated with it, mostly through like One Flew Over the Cuckoo's Nest, and how it's portrayed it as like this kind of punishment and this terrible thing. But the reality is like ECT is like super safe, super effective. Some people will have issues with like memory loss, but that's the minority of people will have that. People can have things like headaches. But again, it's like the most effective treatment a lot of times for depression, can snap people right out of it. I've had a handful of my outpatients as an adult who've done it, and it's been like the thing that's worked the best for them. So that's something that's out there. Since then, there's been things like TMS, transcranial magnetic stimulation, where people will get over the course of like 35, 40 sessions, get like rapid pulses of magnetic beams into the part of their brain to stimulate part of their brain to help with improving mood and depression. And that can be effective. I've seen that be effective for people who suffer more so with like mild to moderate depression, or like it's part of their life, but they're able to kind of like function to some extent, but they're still struggling, right? Functional depression, I guess, is a way to kind of say that. And then more recently, we have things like ketamine and then esketamine. So ketamine is another dissociative class of medication used in anesthesia a lot, to help people who are having an operation so that they don't remember the operation. So we use it in kids, we use it in animals a lot, so they don't like have memories around the operation and the trauma that may be associated with that. And it also helps a bit with pain control. So what people were noticing is that people were coming out of anesthesia and they're like, I feel great. I feel really good. And they're like, oh, let's look at this. And then of course, this has been used illicitly. Ketamine has been used illicitly. It's known as like a rave drug back in like the 80s and the 90s. Very popular for that to like, again, boost mood. And when we start talking about like substances and the quote unquote illicit substances, like, and how they're kind of coming back in vogue a little bit as treatments for all kinds of mental health stuff, is like, because they made people feel good. And people were scared of that. So they cut off research and funding and about it. And now it's like, oh wait, maybe we're onto something with this stuff. So ketamine has been used more recently to help with like depression. And people will go in, they'll get like an IV, and they'll come and they'll repeat that every few weeks, and they'll get like re-upped, quote unquote, on their ketamine. And it can help with depression. It can be really beneficial for people. 2018, 2018, I think it was 2018 or 19 is when the FDA approved Spravato, or intranasal S-ketamine, which is like a form of ketamine, and they put it into a nasal spray. And I do that in my office, and we do great results with that. Again, people who've tried a lot of different things, and this is where they get to. It's the thing that seems to help them the most. There's like a loading phase. They come in twice a week for 4 weeks, then once a week for 4 weeks. To get this done, we have to sit with them over here at the office. They sit here for a couple hours. We monitor their blood pressure, their pulse ox, to make sure that they don't have like a blood pressure spike, or that they don't have like dissociate or hallucinate or anything like that. And that helps them. And then I got tremendous results with depression. I've seen results within like a week of two of going from like severe to mild depression.
Wow.
And it's like really can be significantly life-changing for people.
So in real world clinical practice,
Mhm.
so I know esketamine, Spravato is approved for treatment-resistant depression when someone has been failed by two or more antidepressants. I guess typically, when does someone actually get to get this treatment? Is it really once they're failed by two, the third one is esketamine, or is it sometimes people try it after way more treatments?
Usually it's way more.
Okay.
Yeah, usually it's way more. And, they have lists of medication, pages of medications, like dozens of medications that they've been on,
Yeah.
for the patients that have like come to me about it. More recently, I want to say in the past few months, it's gotten approval so that it can be used alone
Hmm.
as a therapy for depression. Before the last couple of months, you had to still be using an oral antidepressant along with the Spravato to get approval for it. But now you don't have that requirement anymore. So people can be doing just the Spravato itself. So yeah, usually, and then like, and when I'm fighting with insurance companies to get approval for the medication for patients, like they want to see a list of medications that they've been
Yeah.
on, or that they've taken and that they've not done well with for whatever reason.
Okay. And now this brings me to psychedelic medicine. I'd love to hear your perspective on its potential as a treatment for depression, treatment-resistant depression. And along with that, what does the current research tell us, and what are the gaps that still remain?
Yeah. So psychedelics in for depression, like there's a few candidates that are really out there. The one, the biggest buzz is around like psilocybin, magic mushrooms, people call it. But psilocybin is the main one that people are putting their money in. And I'm not sure if you listened to like Dr. David Puder. He did an episode on psilocybin. He did a couple episodes on psilocybin for depression a couple of years ago. I want to say 2, 3 years ago. It was a super, I think they did like 3 hours of like pouring over all the published research about psilocybin to really come to the conclusion to say that like we don't know,
Hmm.
or that there's like minimal benefits from it when we really compare it to other stuff.
Okay.
So that's one thing. I at the same time I say to my patients, and I say to everybody in general, is like there's research and then there's real life. And when people come to me and they say, I had, my buddy had some shrooms and we did some over the weekend and I felt my life transformed and I feel so much better and I gave up smoking and I
Hmm.
stopped being depressed and whatever it is, right? Like no more anxiety, like great, good for you. Awesome. Amazing. That's what we want, right? Like you're doing better. That's all I care about, and I tell them, I was like, now we're kind of going outside the realm of what I'm able to do for you, right? Because technically still psilocybin is illegal, right?
Hmm.
Use of this is like illegal and it's not allowed. You can't go to CVS and get it, which kind of, again, is a whole separate discussion about like prohibition of substances and potential contaminations that can occur because of the black market of all these stuff. Um, but I tell people, I was like, if it's working for you, great. I'm not going to tell you to do something different, but just be aware of like the risks that come along with this, right? And that's ultimately, it's like, be safe with what's going on. So are there people that are going to have benefits from it? Absolutely, right? And there are people who have already had benefit from it. People are swearing by it, right? So if it's working for you, great. I think we need to have more research. I think we need to have more evidence about this stuff. You know, the research that's out there has, again, been kind of inconclusive. I've also looked at like the logistics of it, like what's that really going to look like?
Mhm.
You know, and then based on like what, so if we're doing a hypothetical person, it's like, I'm coming to you and I want to do psilocybin associated psychotherapy or psychedelic associated psychotherapy. What it would involve is you need to have two people in the room
Mm.
with the person, one male, one female, right? You need to have, they both need to have undergone their own like trainings in psychedelic assisted psychotherapy or psychedelic medicine through like certified centers. It's like an 8-hour process, right? So you need like a room, you need a bed, you need this something for that. You know, you need to have all these things, and you're there with them for like the 8 hours, and then there's like 2 sessions. So you need to have like one, and then there's a second one. And I'm looking at it, I'm just like, I'm trying to think of like pricing it out. Like, what is this just logistically going to like cost? And the number that kept coming to me was like, it's going to cost like $10,000.
Yeah.
You know, like that's what it's going to be in reality. To be like, I'm going to take a psychiatrist time for 8 hours, a therapist time for 8 hours, have a facility for it, have the room for it. It's $10,000, right?
Yeah.
Five
Yeah.
to $10,000. I was like, yeah, it's like, I don't know how feasible that's going to be for people, right? So that's something that kept coming up as like a barrier to it, you know? So again, I think, you know, if there's a way to standardize it, make access easier, and then have the process for it easier, I think there's a future for it. Again, I'm excited for it. There are absolutely, again, people who are going to benefit from it. You know, the other one is MDMA or ecstasy, right? Which I know there's a lot of talk about that, how the FDA in the past year like shut it down essentially because there was so much bullshittery that was going on with the trials, right? And there was, again, allegations of like exploitation, of like abuse, sexual abuse, and the sexual assault that was occurring. All this stuff that was like, why are you even putting this in front of somebody with all this terrible stuff that occurred? And it really just like set, you know, set it back years, potentially decades, and potentially forever. Like with how the trials were out there and the research that was really presented. So MDMA is another one that like potentially can be beneficial for people with like trauma, especially PTSD, and depression. And it's a similar setup, right? Like the setup logistically is it can be very complicated and very, very expensive for people. And there's, again, not many people are going to be doing these trainings, which drives up the premium. It becomes, again, the first law of like economics we learn is like supply and demand. There's only a handful of people that are doing this. They're going to be charging all this money, whatever they can, for this potential treatment for people.
Yeah. With MDMA, that was definitely, it was really disappointing to learn about the ethical violations that occurred in, I think it was a phase 2 trial.
Yeah.
The space had actually known about it for quite some time, but then even more details, I think, came out over time. And unfortunately, the sponsor didn't collect safety data that is really standard for clinical trials. That was
Yeah.
disappointing. But yeah, behind that, psilocybin is in phase 3, deep into phase 3 for treatment-resistant depression, and other psychedelics, novel psychedelics behind that. And then some people are trying to see if these drugs can work without the trip, which is
Yeah.
interesting to follow as well. So thank you for sharing your perspective. And I'm also curious, do you and other psychiatrists, maybe friends, is this ever a topic that comes up? And like what are some of what do some of the discussions look like, if you don't mind me asking?
Yeah. I think, I mean, we've talked about it with, with some of my buddies, some of like my old co-residents and stuff. And then like again, other people in the field like I've met online and stuff is I think there's a lot of people that are putting their ears to the ground. Like and I was pleasantly surprised. I jumped into Spravato being like, I'm initially with like my my capitalist kind of mindset of like, I'm gonna be the first person in my area that's doing this. I'm gonna be the person, I'm gonna be the guy. And I was, and I had a lot of people, and then like I started tracking the data myself for my patients, and I was kind of astounded when I saw the data, like what the results were for people.
Hmm.
Like I would, we have to track like their PHQ-9, which is a standardized depression scale. For insurance purposes, they want to like,
Okay.
again, for their approval, like they want to see that like the scores are improving. So I was like, let me just graph this stuff out as well and just see what it looks like, collecting all my patients' data and then putting it there. And I was like, boom, there were like the curves were just like it smacks me in the face when you look at it. Like rapid improvements, and I was like, okay, there's something to this, right? It's why I continue to use it for offer it, and then why I continue to like advocate for its use for certain patients is like because it works for them,
Hmm.
right? Because it really does work and it's really helpful. So again, do I see that there's going to be something like this? Yeah. And I think there are enough people that are in the field. Like I'm in a psychedelic psychiatrist like Facebook group
Hmm.
where people are talking about this stuff and, again, very much keeping their ears to the ground and seeing what needs to be done to kind of like bring this as an option for people. Because I think, going back to what we talked about originally was like, again, we know the medicines aren't always the best, maybe 50 to 60% effective, right? And we're all looking for something else, right? We're looking for something else that could be helpful, more effective, an alternative. And if this is out there and there's people that are going to benefit from it, like why deprive ourselves from this as an option?
Thank you for sharing. And I'd like to ask you, I'm curious. I guess one thing, just as a someone observing the psychedelic medicine space, I guess learning more about the benefit risk profile of these psychedelics obviously is extremely important. So I guess we know that, like you said, we have, even along with the studies, we have anecdotal data. People
Yeah.
stop, smoking cigarettes maybe after an experience. We know it can help a lot of people, but I guess I'd like to see more more of an understanding of the challenging experiences people have as well. I'm curious with S-ketamine, do people ever have times where the experience is challenging and they need extra psychological support afterwards?
I've had like a handful.
Okay.
I wouldn't say a whole lot. I've been again very, very surprised, pleasantly surprised, and very happy that like people have tolerated it really well.
Okay.
I've had like a handful of people who were like said like I had an experience when I was using it or taking it wasn't always the best, but like overwhelmingly positive for most people. I've had a couple of people who had like a negative-ish or more intense kind of experience with it. I've seen people, I've heard people, I've had people who've had like the IV ketamine that's set up like again through all these other clinics and stuff. The and I want to add like the non-FDA approved kind of clinics that are there who are just kind of giving ketamine to people. And I hear more negative responses, more negative experiences with that versus the Spravato.
Okay.
Yeah.
I see. And yeah, there's definitely a big debate I see sometimes online about what's more effective, IV ketamine or Spravato. So that's definitely interesting to learn more about. The final question I have for you, Dr. Mirza, and again, thank you so much for coming on the channel.
Of course.
What excites you the most about the future of psychedelic medicine, and what maybe worries you the most for the field moving forward?
I think the thing that's the most exciting is like having additional tools in the toolkit
Mhm.
and options for people, right? Back when Prozac first came out, like we had a limited number of options. Like that was it. And then we had like Paxil and Zoloft, and those were terrible in their own ways and like side effecty in their own ways, right? So again, we have plenty of these medications which cause plenty of side effects and problems that can be really dramatic. So being able to expand and offer something else is what's really exciting.
Mhm.
It's something that's different, something that could be helpful for people. That's what's exciting. Ultimately, it's like new ways, more ways, different ways of helping people, right? Again, like I don't care, like what the way we get there for a lot of people is. If that's by not seeing me and by seeing your therapist, great. That's fantastic. Like, and if that means like you do like, again, psychedelic associated like psychotherapy and you to go on a shroom trip and that works for you, fantastic.
Yeah.
Like that's ultimately what I'm going for. I don't care how we get there, right? I just want to get to the point of doing better. So I think that's the most encouraging thing about it. I'm also encouraged by the fact that like our discussion, our view on these like substances is changing a little bit, that we can look and see like, you know what, like maybe these things are not these terrible things that we learned about in dare class, right? And that they can have life-changing positive effects for people. And again, like and validate the people who've already had these experiences. Like when people are going to say offhanded comments like, oh, that's just my pot smoking cousin over there on the couch doing nothing with his life. And it's like, if he's fine and doing all right with his life, like nothing's wrong with that. He's not harming anybody. That's, what do I care, right? Like, so what? Like, and don't try to just invalidate their experience and their life with it. So I think that's the really thing that I really appreciate it. The thing that I get worried about is people jumping into it too soon, right?
Mhm.
Or not jumping into it the right way. People who are going to go on, see something like Huberman or Rogan podcast and be like, oh, I'm just going to do like shrooms in my basement and I'm going to be good to go, without everything else that goes into that. Or people just, again, and again, keeping kind of like with the misinformation, people popping up and grifting and just, again, selling non-regulated stuff, non-regulated services, people kind of hopping on just to make a buck.
Mhm.
We saw this during COVID with the rise of like the online direct-to-consumer pharmacies, like things like Dun and Cerebral, who are advertising so much on TikTok for like ADHD. One of these surprising stats is like they were the number 3 advertiser on TikTok behind like Amazon and HBO.
Wow.
Cerebral was. And that's how we had so many people being like, I think I have ADHD. And let me click on this link and I'm going to get hooked up with a nurse practitioner and boom, I'm going to have like a script for Adderall in 5 minutes. Like
Wow.
that's all it takes, right? Like, so that's what I get worried about, is
Yeah.
that again, these venture capitalist tech bro CEOs are going to be like, here's an opportunity for me to make money. Or again, people just kind of jump into it without the knowledge and understanding of like what that involves as a whole.
Yeah, and there's already concerns now. I won't mention any companies, but of ketamine telehealth companies. There's a lot of concern there. So it is definitely
Yeah.
something to really look out for. Listen, Dr. Mirza, thank you so much for coming on the channel.
Yeah, of
And
course.
everyone, if you enjoyed this content, please like, subscribe, comment, and absolutely make sure to subscribe to Dr. Mirza's YouTube channel, The Kicks Shrink. I'll link it down below, and follow him on Twitter for also great mental health information at Sulmoney, SUL. Thank you so much, Dr. Mirza.
Of course, Jake. Wonderful talking with you.